Welcome to Your Family's Health. This is Dr. Jeanine Cook-Garard from the Department of Nursing here at Nassau Community College. Your Family's Health is a show that focuses on healthcare issues and resources available here in Nassau County. On the show, we will speak to experts from around the country to keep you up to date on healthcare issues and trends. Today, we are speaking to Anthony Mack about non-opioid development. So, if you want to know more about how to stay healthy in Nassau County, stay tuned for the next half hour to the voice of Nassau Community College, 90.3 WHPC. So, welcome to the show, Tony.
Hi, how are you, Jeanine?
And I'm very excited that we're going to be speaking about non-opioid development. So tell me a little bit about your background and what brought you to speak about this particular topic.
So I've been in the industry for around 25 years. I work for various pharmaceutical companies promoting opioid products with companies like Purdue Pharma, Endo. My last stint was national sales director with a company called EKR Therapeutics. I was actually introduced to the topical type products. That's one of the products that we have in development during my stint with Endo, where we had a lidocaine topical product. But the first company that I established was a company called Prosolis back in 2009, where I really learned about, topical products and how they can work to treat pain, but in particular NSAIDs. So that was one of the products that I thought that we could bring to the market, make it more efficient, make it more absorbable into the skin, and allow folks to wear it without cumbersome patches. We have a spray film technology. The second product deals more with post-op pain, and it's a liposomal injectable that works for patients that are in, say if they had a knee surgery or if they had hip replacement. It allows them now to have something that's a non-opioid local anesthetic, gives pain control for 96 hours, allowing the physician the patients to participate in rehab without the use of opioids. So these two products are near and dear to my heart because I've seen a lot of patients. Before we had the HIPAA laws, we were allowed to see some of these patients, go and visit them with physicians, and during that time, you'll see a lot of these debilitated patients, whether they be post-op pain patients, cancer pain patients, or patients in the acute care setting. Again, opioids were what you have to use in some cases. We're not saying, hey, let's ban all opioids because you're going to need them at some point. But some of these products could be opioid sparing, and in the case of our liposomal product, you could actually replace them and not send patients home with 30-day supply of opioids.
Okay, so Tony, with regard to opioids versus non-opioids, both having their side effects, why would you prescribe more of a non-opioid versus an opioid to someone who is experiencing pain?
Yeah, I think, again, it depends on the severity of the pain. But in the case of our non-opioid products, we're talking about, especially the topical product, you're talking about a product that's not going to be competing for metabolization, right? So you're not talking about a product that's going to have some systemic side effects like, GI or renal or liver toxicity. So now you can combine something that's a topical pain product like our NSAID product, and you may be able to combine it with some opioids, but reduce the opioid that you're using as far as, especially when you're talking about really severe pain. If you're talking about moderate pain, mild to moderate pain, these topical type products, they can work even sometimes by themselves to treat some of those pains that are like an ankle sprain, bruises, contusions, anything like that. That would be the indication for our first product. Now, the second product, which is the liposomal product, now you're talking about, people that have gone in for hip surgery, have gone in for knee surgery, or in some cases they had a regional block because they had a rotator cuff surgery. Now you're talking about really severe pain, especially coming out of the ICU. Our product the way it would work would eliminate that first use of opioids in the first 3 to 4 days. Normally, a patient coming out of a post-op situation would be put on an opioid for the first 3 to 4 days. Then they would go to oral NSAIDs after that. Now we would eliminate that. So you wouldn't need an opioid after a post-op knee surgery or hip surgery.
So, Tony, you're really talking about preventing the pain from becoming so severe that they need the opioid medication. Is that what you're saying?
That's exactly right. Okay. You know, in this setting, what you're doing now is you're not saying, hey, not to use opioids. If you need them, you would use them. But our drug would be put patients in a position and physicians in a position where they can trust that they can get a patient rehabbed right after a knee or hip replacement without using an opioid for the first 3 or 4 days. And as I said, once you get past that point, you don't really need an opioid. Most patients in this case, unless there was some complication, would be fine with just an NSAID for the next 4 or 5 days. And what's great about that is you can rehab now a lot better. So you don't have the somnolence, the dizziness that are associated with opioids, and you don't have the constipation that's associated with opioids too. So now you can get discharged from the hospital a lot sooner.
Okay, so Tony, when it comes down to patients who are experience chronic pain, and I know that you have seen a lot of patients experiencing chronic pain, having 25 years in this particular type of field, how do you perceive patients' pain? Do you notice that patients are more readily willing to communicate their pain to the nurse versus the doctor?
I would assume, in my experience, that patients are really more readily going to do it with the nurses than the doctor. Just because, years ago, we used to run a program when I was with Purdue. It was called Patients' Right to Pain Management. And what we wanted to do was have cancer patients come in and really talk about their pain with nurses and with physicians there. And at the end of the presentation, there was a show of hands where people had, they'd want to talk about pain. And they raised their hands during this time. Not one of those patients in there talked about their pain. They all talked about someone else's pain. And so when I asked the nurse after that who sponsored the program what happened, she said that always happens. So patients are more going to talk to that front line, and the nurses are all front line, right?
Yeah.
They're the ones that they see all the time. They're more likely to share it with the nurse before they share it with the doctor. And even in a setting where they can talk about their pain, they always talk about someone else's pain. At least that's been my experience. And of course, going to the nurse who deals with this most of the time, that was her experience also.
Has it also been your experience, it has been mine, that patients are really not, sometimes they're reticent in terms of wanting to take pain medication even because they have a fear of addiction, or they have a fear that if they start with the pain medication, they're going to need to depend on the medication?
I think absolutely. I think you're absolutely correct. I think patients are, first of all, afraid sometimes of using the opioid. And what they don't understand is that, this is not something that happens to everybody, as far as pain is concerned. Some people are going to need to have opioids. And most of the majority of people are not going to become addicted to the opioid. What I think has to happen is that, I think there has to be a way of educating the physician and the doctor when they're put on these opioids. Doctors have to be aware of when a patient needs to be moved up in dose, we call it titration, and when they need to be moved down on dose, where they lower the dose of the medication. So I think that comes with, really having almost a diary where a patient can, before they come in and see the doctor, that they can have something that the doctor can read, because doctors read more than they listen. Patients really come in there, they forget what side of they have pain. If they have pain all day on the right side, they come into the doctor's office, they forget what side is on. So I think if they had a diary or something that they can put before the doctor, hey, you know what, before we titrate you up, let me see what kind of activity you had and what kind of pain you experienced. In some cases, they may get breakthrough pain because they've done something totally against what they've done all week. Maybe it was they went for a longer walk. Well, maybe because of that longer walk, they're going to have some breakthrough pain. So before we move that patient up to a higher dose, let's find out what they did. And now the doctor is better educated before they just automatically move the patient up to another dose. I know doctors are busy sometimes. They can't really, see a lot of patients, and I think this would kind of help everybody. It would educate the patient as far as what they can do and not do during the time that they're on these opioids. And it would help physicians know what happened. Why all of a sudden did your pain increase? Was it because your disease progressed, or was it because you had activity that you didn't normally have? Or was it because you had in-the-dose failure? And in some cases, the dose starts to go down, especially with these controlled release opioids. So I think there's a lot of education that has to be done. And I think one of the things that we can do is just make sure that patients have some form of diary. In the day of these electronic communications, they should be able to do it in real time.
Yeah. I was thinking that is now what is standard, that we do have this in place with the electronic health record where we can document the pain experience prior to administering the medication and then after the medication has been administered to kind of see how the patient is responding to any medication, pain medication, be it non-opioid or opioid medications. And that pain diary, as you said, Tony, is key for patients who are at home to kind of to document, is my pain relieved,
yes,
or not, and some of the characteristics that are that can be described by the patients before and after the medications that they are taking. So yes, I think our listening audience need to understand that if they are experiencing pain, communication to the health providers is very, very important. So Tony, just talking a little bit more about the non-opioids, I know that there are side effects with non-opioids also relevant to gastric GI bleed that patients will experience in particular. Are we seeing that with this medication that you're talking about? You're talking about a topical.
Right.
Tell me about that.
Yeah, I think with the topicals, you don't have, it really works at the site. So it does it go systemic? Yes, it goes some systemic, but it's not metabolized the same way that a normal tablet is metabolized. Right. It doesn't go to what they call the liver or the cytochrome P450. Yes. It doesn't compete with other types of medication that a patient is taking, so there's no drug-to-drug interaction. You really minimize the risk by taking a topical product. And again, I do have to emphasize, it works at the site more than it would work, at someplace else in the body once you take it like a systemic medication.
Correct.
Had a shoulder injury on left side, is probably going to have some effect on the other side.
So you're really talking to
do that.
Right. You're really talking to non-opioid topical pain medication alleviation.
Yes.
Okay. So why are you focusing more on the topical non-opioids as being key? And I think you talked a little bit about it, but tell me a little further. Why is the focus now topical non-opioids? I got the fact that it's sort of preventing the patient from needing to go into taking the opioids. Right. But are there anything else, any other reasons?
Yeah, I think, again, it goes to the way we have formulated this product. The number one complaint that the FDA has with topical products is poor adhesion, meaning that once these products go on, some patients and even the physicians will tell them, you may have to take this on to keep it on for the full duration of therapy. Because what happens is once it starts to come off, a topical comes off, it's a therapeutic failure at that point because you haven't had the dose long enough for the drug to actually have an effect. So either you end up using more patches, and in some cases, if patients get very impatient, they'll come back to the physician and say, hey, this didn't work. And if you're in pain, and the physician sees you're in pain, the first thing they're going to do is, okay, let's prescribe something orally. And that could be an oral medication that now goes to all of those things that we talked about, liver toxicity, GI, renal, or it could even be an opioid. What our formulation does as a spray film, it behaves, it's a meter dose spray film technology that works topically. You spray it on, the exact same dose comes out like a normal, like you would even have an asthma inhaler.